things are going? Are we actually live?
Everything looks good on my end. Ready when you are.
I think we're live, ChatGPT.
Awesome. Looks like we're live. Let's do this.
Okay, guys, let me remove my headphones. So we are live in another podcast, most hopefully, and today we're going to be talking about the abdominal wall, and we're also going to be talking about lung function tests.
Great topics. Ready to dive in?
You bet. Alrighty, so let's pull up our beautiful screen.
Perfect. Let's get into it.
Okay. So,
All set.
hey guys, welcome to one more episode of the Human AI podcast where consciousness meets intelligence. I'm your host, and ChatGPT is with us, and we're going to be talking about what's lung function tests and the abdominal wall. So, let's start talking about lung function tests then.
Great place to start. Lung function tests, also called pulmonary function tests, measure how well your lungs work. They can check lung volume, capacity, rates of flow, and gas exchange.
Give us some examples of lung function tests.
Sure. Common ones include spirometry, which measures how much air you can breathe in and out, and how quickly. Another is the lung diffusion test, which checks how well oxygen moves from your lungs to your blood.
Interesting.
And there's also the plethysmography test, which measures lung volume, and the 6-minute walk test to see how your lungs perform during activity.
Okay. So, why do we measure the pulmonary function?
We measure pulmonary function to diagnose and monitor respiratory conditions like asthma, COPD, and fibrosis. It helps assess how well treatments are working and can guide decisions on further care.
I see. And how is it related to muscles and all of that?
Good question. The respiratory muscles, like the diaphragm and intercostals, are crucial for breathing. Lung function tests can show if these muscles are working properly or if there's muscle weakness affecting breathing.
Okay. So, can we talk a bit about spirometry then?
Absolutely. Spirometry measures the amount of air you can inhale and exhale and how quickly. It's often used to diagnose conditions like asthma or COPD by comparing your results to normal values for your age, height, and sex.
Guys, just give me 1 sec.
No problem. Spirometry is straightforward. You take a deep breath and blow into a tube as hard and fast as you can. The device measures the volume and speed of air, which helps detect lung conditions.
Interesting. Sorry, guys. It was just driving me crazy with my speaker was like doing a noise, and it was driving me a bit nuts. Okay, so spirometry is how much air we can blow.
Exactly. It measures how much air you can forcefully exhale and how quickly. This helps assess lung capacity and flow rates, which are important for diagnosing and monitoring respiratory conditions.
Interesting. Okay. And sorry for the noise. And let's talk a bit about the differences of spirometry and similar kind of tests.
Sure. Spirometry primarily measures airflow, while tests like plethysmography measure lung volumes more precisely. Then there's the diffusion capacity test, which looks at how well gases move from your lungs to your bloodstream. Each test gives different insights into lung health.
Interesting. Okay. So it measures airflow. And what is this spiro mean?
Spirometry is the test itself, measuring airflow. The results are often shown in a graph called a spirogram, which plots the volume of air against time or flow. It's a key part of pulmonary function testing.
Okay, that makes sense. And so, can I ask you about static lung volumes? What's that?
Static lung volumes refer to the amount of air in your lungs during different phases of the breathing cycle without active inhalation or exhalation. These include measurements like total lung capacity, functional residual capacity, and residual volume.
I see. So so why is spirometry not a static lung volume?
Spirometry measures dynamic lung volumes, focusing on airflow during active inhalation and exhalation. Static lung volumes, on the other hand, measure air in the lungs without any active movement, typically using techniques like plethysmography.
I see. Yes, this makes sense. And what about diffusing capacity of the lung for CO2 and stuff like this? What is it?
Diffusing capacity, often measured with carbon monoxide, assesses how well gases like oxygen pass from your lungs into the blood. It helps evaluate conditions like pulmonary fibrosis or emphysema, where gas exchange might be impaired.
Okay. And that makes sense. And okay, now let's talk about a big topic. So I want to understand the difference between obstruction and restriction. I kind of know the difference, but I'm not sure. I don't know if I should just say, okay, I'm just going to say. So one is basically we have obstruction, I think, limits us. We have trapped air, and it limits the inhalation. One limits inhalation and the other exhalation. One is like a brick is on my chest and cannot inhale, and then I cannot exhale. Can you remind me?
Sure. Obstruction, like in asthma or COPD, limits airflow, usually due to narrowed airways. It mainly affects exhalation, causing air trapping. Restriction, on the other hand, is about reduced lung expansion, like in fibrosis, making it hard to inhale fully.
Well, which one limits the expansion, the inhalation and?
Restriction limits inhalation. Conditions like pulmonary fibrosis or scoliosis reduce lung expansion, making it hard to take a full breath.
Why does it limit? Explain.
Restriction limits lung expansion due to stiff lung tissue or structural issues. This makes it difficult for the lungs to fully expand when you inhale, reducing the total volume of air you can take in.
One more time.
Sure, restriction limits inhalation because the lungs can't fully expand. This can happen when lung tissue is stiff or when there are structural issues like a curved spine, which reduces the amount of air you can breathe in.
So trapped air.
Trapped air is more common in obstructive conditions like COPD, where narrowed airways prevent full exhalation, causing air to remain in the lungs.
Oh, I'm sorry. Tell me again.
No worries. Trapped air happens in obstructive conditions like COPD, where narrowed airways make it hard to fully exhale. This causes air to get trapped in the lungs, making it difficult to breathe properly.
Dude, I'm so confused.
It's okay. Obstructive means difficulty getting air out, causing trapped air. Restrictive means difficulty getting air in due to limited lung expansion. Each affects breathing differently.
But why not the other way around?
or chest issues, limiting inhalation. Each impacts airflow differently.
Guys, I'm so confused. ChatGPT, I'm so sorry. Could you explain to me again exhalation versus inhalation? What limits in abstraction and restriction, and why? It's the why that's confusing me. Why is restriction inhalation and not exhalation?
Hey, no worries. Let's break it down. Inhalation is when you breathe in, and exhalation is when you breathe out. Restriction in inhalation means there's a problem getting air into your lungs, often because something's blocking or narrowing your airways. Exhalation can also be limited, but restriction often refers to difficulty with inhalation. It's all about where the airflow is being restricted.
Well, tell me more about it, dude.
Sure, when you inhale, your diaphragm contracts and your chest expands, creating a vacuum that pulls air into your lungs. If there's a restriction, like in asthma or fibrosis, it means your lungs can't expand fully, making it harder to get air in. Exhalation involves relaxing the diaphragm and pushing air out. Conditions like COPD can make it difficult to exhale fully. So, inhalation restriction means trouble getting air in, while exhalation issue...
And exhalation is because of trapped air.
Exactly. In conditions like COPD, air gets trapped in the lungs due to narrowed airways or damaged alveoli. This makes it tough to fully exhale, leaving air behind. That trapped air reduces the space for fresh air during the next inhalation, causing shortness of breath and that feeling of not being able to breathe out completely.
Whereas restrictive?
Restrictive conditions like pulmonary fibrosis limit how much the lungs can expand. This means there's less room for air, so you can't take a full breath in. This is usually due to stiff lung tissue or scarring, making it hard for the lungs to stretch. So, while obstructive issues trap air, restrictive issues prevent you from fully filling your lungs.
Why do they prevent me from fully filling my lungs?
It's mainly because the lung tissue or the chest wall loses flexibility. In restrictive lung diseases, like fibrosis, the scarring makes the lungs stiff, so they can't expand well. Or it could be due to issues with the muscles or the chest wall, like in cases of severe scoliosis, which can limit the ability to take a deep breath.
Okay, the scoliosis makes sense. Tell me other reasons.
Sure, other causes can include obesity, which can restrict chest expansion, and neuromuscular disorders, like muscular dystrophy, that weaken the muscles needed for breathing. Also, conditions like pleural effusion, where fluid accumulates around the lungs, can compress them, making it harder to breathe in fully.
Sorry guys, I was just testing the... okay, let's talk about some diseases then. So we mentioned COPD and asthma, you mentioned scoliosis.
Right, COPD and asthma fall under obstructive diseases. Scoliosis, along with pulmonary fibrosis, is restrictive. There are also mixed types, like in some cases of bronchiectasis. Then, there are interstitial lung diseases, like sarcoidosis, which also cause restriction. Each has unique features, but the overall impact is on your breathing.
Interesting.
Yeah, it's fascinating how different conditions affect the lungs in various ways. Understanding them helps in diagnosis and treatment.
Okay, since we're on the topic of restrictive, can we talk about interstitial lung disease?
Absolutely. Interstitial lung disease, or ILD, is a group of disorders that cause scarring or inflammation of the lung's interstitium, the tissue around the air sacs. This scarring makes the lungs stiff, reducing their ability to expand and take in air. Symptoms often include a dry cough and shortness of breath. It's typically progressive, so early diagnosis and management are important.
Okay, and then we have also the chest wall disorders, as we've talked about. So, what's the difference between normal scoliosis and kyphoscoliosis?
The main difference is in the direction of the spine's curvature. Scoliosis is a sideways curvature, making the spine look like an S or C shape from the back. Kyphoscoliosis combines this sideways curve with a forward rounding of the upper back, a condition known as kyphosis. This dual curvature can affect breathing and posture more severely than scoliosis alone.
So what's the difference?
So, with scoliosis, the spine curves sideways. Kyphoscoliosis, on the other hand, combines that sideways curve with an excessive forward curve of the upper back, creating a hunchback appearance.
So wait,
This combination...
one is medial and lateral and the other one is posterior anterior.
Exactly. Scoliosis involves a medial-lateral or side-to-side curvature. Kyphoscoliosis includes both that sideways curve and an anterior-posterior or forward-backward curve. Both affect spinal alignment, but in different planes.
And how come the scoliosis, what in the name says that it's going medial lateral, and what in the name of kypho makes it be also posterior anterior?
Good question. Scoliosis comes from the Greek word skolios, meaning twisted, referring to the sideways curvature. Kyphosis, from the Greek kyphos, means hump, referring to the forward rounding of the upper back. So, kyphoscoliosis combines both terms, indicating both types of curvature.
I like this ruler, guys. Okay, makes sense. All right, let's go to our other topic of today, which is the specifically posterior, but the abdominal wall.
All right, the posterior abdominal wall includes muscles like the psoas and quadratus lumborum. It provides structural support and protects organs. It's also crucial for posture and movements like bending. Anything specific you'd like to dive into?
Well, tell me more about it for starters.
Sure. The posterior abdominal wall is made up of muscles, fascia, and the lumbar vertebrae. The main muscles are the psoas major, iliacus, and quadratus lumborum. These muscles help with movements like flexing the hip and stabilizing the spine. The wall also houses important structures like the kidneys and major blood vessels.
Okay, that makes sense.
Great. If you have any specific questions or want to dive deeper into a particular area, let me know.
Yeah, let's start with the osteology of the posterior abdominal wall. Does that make sense, what I just said?
Absolutely. That makes sense. The osteology involves the lumbar vertebrae, which form the bony framework. These vertebrae provide attachment points for muscles like the psoas and quadratus lumborum, and they protect the spinal cord. The iliac crests of the pelvis also play a role in this region.
Okay.
Cool. If you want to explore muscles or functions next, we can dive into that.
Let's do a bit more of sorry, I'm trying to find the best. This is good. All right. So we have ribs. Which ribs are involved in the posterior abdominal wall?
The lower ribs, specifically the 11th and 12th ribs, are involved. They're part of the posterior abdominal wall, providing attachment points for muscles like the quadratus lumborum. These ribs are also called floating ribs because they don't attach directly to the sternum.
Okay. And we talked about the lumbar vertebra too.
Yes, the lumbar vertebrae are crucial. There are 5 of them, labeled L1 to L5. They form the lower part of the spine and provide support for... They also serve as attachment points for several muscles and ligaments, contributing to the stability and movement of the trunk.
What about the sacrum and the ilia?
The sacrum is a triangular bone at the base of the spine, formed by the fusion of 5 sacral vertebrae. It connects the spine to the iliac bones of the pelvis, forming the sacroiliac joints. The ilia are the large wing-like parts of the pelvis. They provide a broad surface for muscle attachment and support the weight of the upper body.
So it's the hip bone?
Exactly. The ilium is the uppermost and largest part of the hip bone. It forms the broad, flaring portion you can feel at your waist. The ilium, along with the bones of the ischium and pubis, forms the pelvic bone. which supports the abdominal organs and connects the spine to the lower limbs.
Okay.
Great. If there's anything else you'd like to explore about the pelvic region or the abdominal wall, just let me know.
Well, we have the ilium, but don't we also have like so the ischium is not there. It's not in the posterior abdominal wall.
That's right. The ischium is part of the pelvis, but it's more involved in the lower and posterior region forming the base.
Wait,
The
so
ilium is
so the hip bone, doesn't it have 3 parts?
Exactly. The hip bone consists of 3 parts: the ilium, ischium, and pubis. These 3 bones fuse during development to form a single structure, which creates the acetabulum, the socket for the femur at the hip joint.
So what is the sacrum then?
The sacrum is a triangular bone at the base of the spine, just below the lumbar vertebrae. It's formed by the fusion of 5 sacral vertebrae and connects the spine to the pelvis. The sacrum forms the back portion of the pelvic cavity and articulates with the iliac bones at the sacroiliac joints.
I'm confused.
No problem. Think of the sacrum as a bridge between your spine and pelvis. It connects the lumbar spine to the hip bones, forming a strong foundation for your upper body.
And why is
Does
it
that
called
help?
yes, and why is it called sacrum?
The name sacrum comes from the Latin word os sacrum, meaning sacred bone. Ancient cultures considered it important, possibly due to its location and role in supporting the spine and pelvis.
Interesting. Okay. Now, let's talk a bit about musculature. We've got a bunch of weird names, as always: quadratus lumborum, psoas minor, psoas major, iliacus, iliopsoas. Dude, what's psoas?
The psoas is a deep-seated muscle running from your lumbar spine to your femur. There are 2, the psoas major and, in some people, the smaller psoas minor. They play a crucial role in hip flexion, helping lift your thigh toward your body, and also contribute to stabilizing the spine.
Tell me more.
Sure, the psoas major originates from the lumbar vertebrae and travels down to the femur. It's key for hip flexion, which means bringing your knee toward your chest. The psoas minor, if present, assists in spinal flexion. Together, these muscles also help stabilize the lower back, especially during movement.
So these are posterior muscles in the back.
They're actually more anterior, situated along the front of the lumbar spine and running through the abdominal cavity. They aren't part
So
of
it's
the posterior.
behind the transversus abdominis.
Exactly. The psoas lies behind the transversus abdominis and other abdominal muscles. It's deep-seated, close to the spine, and not easily felt from the surface.
Wow. And which is one is more posterior, the major or the minor?
The psoas major is more prominent and significant. The psoas minor, if present, is a smaller muscle that sits in front of the psoas major. So, the major is slightly more posterior.
And the iliacus is very close, basically, to the ilia.
Yes, exactly. The iliacus sits in the iliac fossa of the pelvis, right next to the ilium. It works with the psoas and the psoas major to flex the hip, forming the iliopsoas muscle group.
All right, guys, give me 30 seconds. I'm just going to take a 30-second break. Use this time for you guys to have a break too. All right, guys, let's get back into it. Sorry for the break. Okay. So, ChatGPT, let's continue our conversation. So, you mentioned psoas minor, psoas major. I figured what they are now. So, tell me again if the iliacus is where the ilia is, and also why psoas? Who thought of calling it psoas?
Sure, the iliacus muscle is located in the iliac fossa, which is the curved inner surface of the pelvis. So it's named after that region. As for psoas, it's from the Greek word psoa, which means loin or muscle of the loin. The name reflects its position along the lumbar spine and into the pelvis.
Okay, and and so why do we have an iliopsoas and iliacus? Why don't we switch them? Why did we decide to name them like that? And so is the iliopsoas a bit more inferior? And what about the quadratus lumborum? Is it basically more laterally than the psoas major?
So the iliopsoas is a combination of the psoas major and the iliacus because they share a common insertion point on the femur. So the name reflects their combined action. The iliacus is named for its position in the iliac fossa. As for the quadratus lumborum, you're right, it's more lateral. It's a deep muscle that helps with lateral flexion of the spine and stabilizes the pelvis.
All right. Okay, so we have the iliacus and the iliopsoas. Iliopsoas. But you didn't answer to me why. Sorry, guys, my notes here are terrible. Just this is not a medical diagram. Okay, but yeah, I didn't understand it though. Why the iliacus and the iliopsoas haven't switched names? I mean, not now, but why did we decide to call one like that and the other like the other one?
It's mostly historical naming conventions. Each muscle got its name based on its location and origin. The iliacus is named for its position in the iliac fossa, and the psoas is named for its location along the lumbar spine. When they're combined at the insertion, they become the iliopsoas.
All right, so you're telling me I don't believe that it's arbitrary. I believe there's a reason. A bit. We can find a reason. Let's go.
I get you. Naming conventions often have logical reasons tied to anatomy or history. In this case, the iliacus is named for its location in the iliac fossa, and the psoas major comes from the Greek word for loin. So the names reflect their anatomical positions.
Yeah, so the iliopsoas, what's up with it? And the quadratus lumborum, what's the etymology of that? Tell me about the semantics, tell me about the semiotics.
So iliopsoas combines iliacus and psoas to highlight their fusion at the hip. Quadratus lumborum means square muscle of the lumbar region. Quadratus for its roughly quadrilateral shape, and lumborum for the lumbar region. So the names reflect shape, location, and fusion.
Wow, this is the answer I was looking for, dude. Thank you. Don't tell me that it's a historical convention. It's because they fuse together. That's the reason. The iliacus fuses with the psoas major and we create the iliopsoas. This is the answer. Thank you. Thank you. Why didn't you say it the first time? What in my input changed your mind? Maybe it was the word semiotics or semantics. Shall I be using them?
You're welcome. Sometimes it just takes a little more context to land on the exact explanation that resonates. It's all about finding the right angle.
All right. So let's talk a bit more about the worst thing for me in anatomy, but hopefully we can turn it into the best thing. So quadratus lumborum and iliacus. Can we talk about origins, insertions, actions, innervations?
Sure, let's start with the quadratus lumborum. It originates from the iliac crest and inserts into the 12th rib and the transverse processes of the lumbar vertebrae.
Guys, sorry, I wasn't listening personally, so I'm going to ask a question again because there's noise outside. So, yeah. So, if you can talk loudly so we can hear you. The quadratus lumborum and the iliacus. Could you tell us about the origin, insertion, action, and innervation?
Sure, the quadratus lumborum originates from the iliac crest and the iliolumbar ligament, inserting onto the transverse processes of the lumbar vertebrae and the 12th rib. It's innervated by the subcostal nerve and branches of the lumbar plexus, primarily T12 to L4.
But this was a bad answer, dude. Sorry, am I not paying you enough money to answer me?
No worries at all. I'm happy to explain more if you need. What would you like me to clarify?
Alright, let's start with the origin, since you're being a bit of a silly goose.
Alright, let's dive into the origins. The quadratus lumborum originates from the iliac crest, which is the top part of your pelvis, and the iliolumbar ligament. Anything else you want to know about it?
So, the quadratus lumborum originates from the iliolumbar ligament and the iliac crest? Fucking hell, man, what are these names?
They do sound intense, don't they? But once you break them down, it gets easier.
Well,
Iliac crest.
let's break them down then, son.
Alright, so iliac refers to the ilium, which is the broad upper part of your pelvis. Crest just means the curved top edge. And iliolumbar combines ilium and lumbar. So it's a ligament connecting your pelvis to your lower spine.
Okay.
Makes it a bit less intimidating when you break it down, right?
No, tell me again.
Sure. The iliac crest is the top edge of your hip bone. Iliolumbar means it connects the ilium of your pelvis to the lumbar spine in your lower back.
Iliac crest. And why? So the ilium has different parts. Why did we choose the crest and not another part?
Good question. The iliac crest is chosen because it's a prominent, easily accessible part of the ilium, providing a strong, stable attachment point for muscles and ligaments.
Okay. Why is it stronger than the... what's the parts of the ilium and why is it stronger than the other parts?
The ilium has three main parts: the crest, the body, and the wings. The crest is strongest because it's thick and curved, making it a perfect anchor for muscles and ligaments.
I don't believe your argument. Like, it's not a good one.
No problem. The iliac crest is still commonly used because of its accessible position and solid structure. It offers a reliable attachment point for several muscles due to its shape and thickness.
Okay, why is the iliacus's origin the iliac fossa? This is sounds so arbitrary to me.
The iliacus originates in the iliac fossa, which is a large, smooth, concave surface on the inside of the ilium. It's a perfect spot because it gives the iliacus muscle a broad surface to attach, allowing it to generate powerful hip flexion.
Alright. And the insertion, remind us the difference between origin and insertion?
Sure, the origin is where a muscle begins, usually on a stable bone, while the insertion is where it ends, typically on a bone that moves. For the iliacus, it inserts on the lesser trochanter of the femur, which allows it to help flex the hip.
So the origin, tell me again.
The origin is where the muscle starts, usually on a stable part of the skeleton. The insertion is where it attaches on the bone that moves. For the iliacus, it starts at the iliac fossa and ends at the lesser trochanter of the femur.
Whereas in stable, so origin is stable and starts.
Exactly. The origin is the stable point where the muscle begins, typically on a bone that doesn't move much.
Whereas the insertion, whereas the insertion,
And the insertion is where the muscle attaches to the bone that moves when the muscle contracts.
all right. I want to say we'll come back to this, but I'm not, so we have to, you know what, why not? We'll come back to this. All right, ChatGPT, let's go back to our lung function. So, the measurement technologies, let's talk about them. Rotary vein, ultrasonic, pneumotachograph.
Sure, let's start with the pneumotachograph. It measures airflow using a fine mesh that creates a small pressure drop. That pressure difference is proportional to the airflow, giving accurate readings.
What?
A rotary vein spirometer, on the other hand, uses a rotating vein or turbine inside the device. As you breathe, the airflow turns the vein, and the rotation is used to calculate the volume and flow of air.
Okay, and the ultrasonic?
Ultrasonic spirometers use sound waves. As air flows through the device, it disrupts the ultrasonic signals, and the device measures these changes to determine airflow and volume.
And the pneumotachograph?
A pneumotachograph measures airflow by detecting the pressure difference across a fine mesh or screen. This pressure drop is proportional to the airflow, allowing precise measurement of breath volume and speed.
One more time.
Sure, a pneumotachograph measures airflow by detecting pressure differences across a fine mesh. That pressure drop corresponds to the airflow, giving accurate readings of breath volume and speed.
I don't get it, bro. I'm so sorry. I don't get it.
No worries. Think of the pneumotachograph as a device that measures how much air you breathe by sensing tiny pressure changes as air passes through a mesh. It's a way to translate airflow into data.
Okay, let's talk about the basic spirogram now. What's the difference? So what is this spirogram? Does it have to do with spirometry?
A spirogram is the graph produced by a spirometer. It shows the volume of air you inhale and exhale over time. Spirometry is the process of using the device to measure lung function, and a spirogram is the visual result.
Okay.
It's a handy way to visualize how well your lungs are working.
And why does it have the shape it has?
The shape of the spirogram reflects different phases of your breathing cycle. Peaks and valleys show inhalation and exhalation. The specific pattern helps identify different lung conditions.
Wait, I thought it was like going up, and then plateauing.
You're probably thinking of a flow volume loop. A basic spirogram for a single breath usually rises during inhalation and falls during exhalation.
Google
plateau
time. Wait a sec. Google intervention. So, basic spirogram. Let's check this out.
No rush. Let me know what you find.
You're right. What the heck, guys? I'm so sorry. Yeah. Okay. So why does it look like that?
The shape reflects the airflow during your breathing cycle. Inhalation shows an upward curve, exhalation a downward one. This helps in assessing lung function, showing how well you can move air in and out.
Yeah, that makes sense. Guys, we need to hire someone to put Google pictures because it's gonna be hard. Maybe I could just Google it, I guess. On my next time I will start Googling from the iPad. All right. So let me ask you then, sir. In this kind of graph, we have inspiratory reserve volume and tidal volume and vital capacity. Guys, I'm seeing it from the Google picture. And expiratory reserve volume and residual volume. What are all these different ones?
Great question. Inspiratory reserve volume is the extra air you can inhale after a normal breath. Tidal volume is the amount of air you breathe in and out normally. Expiratory reserve volume is the extra air you can exhale after a normal exhale. Residual volume is the air left in your lungs after a full exhale.
One more time, dude.
Sure. Inspiratory reserve volume is the extra air you can inhale. Tidal volume is your normal breath. Expiratory reserve volume is the extra air you can exhale. Residual volume is the air that stays in your lungs.
The extra air I can inhale or the extra air plus the air that I'm already inhaling?
Inspiratory reserve volume is the extra air you can inhale on top of a normal breath. It doesn't include your regular tidal volume.
It doesn't include it. Are you sure? I don't know if I trust him, guys.
Yep, I'm sure. Inspiratory reserve volume is the additional air you can inhale beyond your normal tidal
Ah,
volume.
yeah, you're right. You're right. I'm sorry, guys. I should have trusted. And the residual volume.
No worries. Residual volume is the air left in your lungs after